Welcome to the 9th episode of the Heart Failure Association of India Virtual Heart Failure Masterclass. We have two programs today. The first is a talk on management of heart failure with preserved ejection fraction in 2025 by Dr. Kavita Sharma, who is a HFSA faculty from USA. This will be followed by a case presentation. The case is being presented by Dr. Venkatraja, Dr. Bharat and Subhash from NIMS, Hyderabad. And the student panel is Dr. Harjab Singh, Dr. Samir Pura, and Dr. Huda. At the examiners panel, Dr. Jaganmohan Taragan, former head of the Department of Cardiology at Sri Chitra Institute, Trivandrum, Dr. Sudhir Kumar, former professor of cardiology at Government Medical College, Kottayam, Dr. Hilal Ahmad Rathar, professor and head of the Department of Cardiology at SKIM Srinagar, and Dr. B. Srinivas, professor and head Department of Cardiology at NIMS, Hyderabad. So we'll now start with the first program. That is a talk from Dr. Kavita Sharma. We look forward to a very educative talk from her. She's a board member of Heart Failure Society of America, associate professor of medicine, director Heart Failure and Cardiac Transplant, and in Johns Hopkins University Heart Failure Preserved Ejection Fraction program, Johns Hopkins Hospital. Over to the presentation.
Hello and welcome to our next talk. It's really an honor and a pleasure to be invited by the Heart Failure Association of India to present as part of the Heart Failure Masterclass series. My name is Kavita Sharma. I'm an associate professor of medicine and I'm the director of heart failure and heart transplantation at the Johns Hopkins University School of Medicine. I'm also the director of a dedicated heart failure with preserved ejection fraction clinic and program. And it's really my pleasure to speak with you today about heart failure with preserved ejection fraction, or HFpEF as we call it, diagnosis and treatment in 2025. Here are my disclosure and funding resources. As you can see, we are going to begin with a clinical case, and I'm going to speak briefly about the changing paradigm in epidemiology of HFpEF, particularly in the United States and the Western world, but we are increasingly seeing this in Asia. I will briefly mention some of the work we are doing at Hopkins in understanding mechanisms from myocardial tissue, as well as closing out with a discussion of HFpEF treatments and guideline therapies today. So beginning with the patient case, this is a 61-year-old female referred to our HFpEF clinic in the last 2 years with a history of hypertension, obesity, sleep apnea, and prediabetes. Very common presentation to our clinic. She presented with 2 years of progressive dyspnea with walking, two-pillow orthopnea, symptoms of bendopnea, which is the symptoms of shortness of breath when bending over and is actually quite sensitive and specific to the heart failure diagnosis, with occasional PND. Her BMI was over 40, hypertensive on visit at 140/70, in sinus rhythm. She was an obese African-American female, quite labored, getting onto the exam table and around the room, with signs of vascular congestion, including elevated JVP, positive HAR, relatively clear lung exam, relatively unremarkable cardiac exam with no significant murmurs, and some edema in the legs. Here is a summary of her laboratory testing. As you can see here, electrolytes were fairly normal. However, her creatinine shows signs of mild CKD, hemoglobin A1C of prediabetes range, and interestingly, an NT-proBNP, so this is our natriuretic peptide assessment of 52, which is within normal range on our nomogram. Under 150 is generally considered normal. Echocardiogram of note with preserved LV ejection fraction of 60 to 65% range, relatively normal chamber sizes as well, and an E2E prime reading of 9.3, which was read as normal diastolic filling pattern for age with normal RV size and function. Re-EKG otherwise showing normal sinus rhythm. So in a case like this, the question is, what are the next steps? Is this HFpEF, and do we have enough to call this HFpEF and begin treatment? Would you empirically then treat this patient with guideline therapies, or is more diagnostic testing needed? Now, probably by the way I'm asking the question, you will guess that the answer, at least to us in our program, is to get more testing, but you would not be wrong to begin empiric treatment if that diagnostic testing modalities were not, for example, available. Let me pause here and remind everybody of definitions from the 2022 American Heart Association, American College of Cardiology, and HFSA guidelines. Heart failure with reduced ejection fraction is still defined as a clinical syndrome of heart failure with an LVEF less than 40%. And heart failure with preserved ejection fraction is essentially the same with an LVEF of greater than or equal to 50%. There is now language in the guidelines that includes some evidence of spontaneous or provocable increased LV filling pressures. That could be in the form of elevated natriuretic peptide or non-invasive or invasive measurement of LV and diastolic pressure. Please note that there is now new language around the mid-range ejection fraction, as you can see, and those who were previously low and now improved, and they are now termed heart failure with improved ejection fraction. So what are the diagnostic tools that we have in a patient that you might see in clinic where you are suspecting HFpEF, but you are not entirely sure? There are two prediction scores that have now entered into the guidelines that have been validated in a number of cohorts. The first comes from the Mayo Clinic, and this is the H2PEF score. The second is from the European Society of Cardiology, and this is the HFAI score. In a recent JACC state-of-the-art review, we sort of combined the two to provide an algorithm to practitioners. So for the patient coming in with unexplained dyspnea, maybe some signs of congestion, but not very clear, these scores can be utilized to predict the risk of having HFpEF. The H2PEF score focuses on more clinical comorbidities. The HFA-PEF score is more focused on morphologic and biometric assays. Both scores provide a low probability, intermediate, and high probability score. And based on that score, whether further testing is needed or treatment can be begun, or if the risk is too low and this is unlikely to be HFpEF. Now, interestingly, our patient, who we just heard about, scored only a 2 by the HFA-PEF scoring algorithm. And this is the one primarily based on echo and biomarkers. And that would put her in the low to intermediate probability risk range, and scored a 4 on the H2PEF score. And this is the score, again, based on comorbidities. And primary comorbidities for her, primarily hypertension and obesity, and some evidence of elevated filling pressures. So for both scores, she would fall in that intermediate risk. And this is a very, very common scenario for HFpEF patients presenting to our clinic. What do we do in the real world? In our Hopkins program, we use an ejection fraction of over 50% as our threshold cutoff for EF. There must be signs and symptoms of heart failure, not all of them, but some of them, and some objective evidence of a cardiac problem. And that sounds very oversimplified, but there really should be some evidence of a mechanistic issue, whether that's elevated natriuretic peptides, some evidence of structural heart disease, hemodynamic evidence of elevated pulmonary capillary wedge pressure or LV and diastolic pressure, or a rise in those metrics with exercise with provocation. So in this particular case, we took the patient to the cath lab, and we have a very low threshold to perform right heart catheterization, and almost all patients are done with exercise. And as you can see here at baseline, relatively normal filling pressures, RA pressure of 8, normal PA pressures, a wedge pressure of only 11, and a cardiac output in normal range. And based on resting numbers alone, one might say, well, this is not HFpEF, not meeting the criteria of a wedge pressure over 15 at rest. However, with exercise, and not very far into exercise, only 35 watts or 3 stages of supine bicycle exercise, we see the RA pressure rise to 18, PA pressure to 55 over 30 with a wedge pressure of 30, clearly meeting criteria for HFpEF with that exercise-induced wedge pressure exceeding 25 millimeter mercury. And so we now have a diagnosis of exercise-induced HFpEF, which really then can help guide the patient in terms of treatment and where to go next. Now, just from a bit of historical perspective, the very first report of HFpEF, at least in the United States, came from Eric Topol, Tom Trail, and Nick Fortuin when they were actually all at Hopkins. This is a paper from the 80s describing 21 patients, all predominantly women, who presented with very dramatic symptoms of flash pulmonary edema, dyspnea on exertion. The patients, interestingly, were all lean and hypertensive, and this is the former phenotype of HFpEF that we used to see. Older women with hypertensive heart disease, stiff left ventricles with thick LVH signs, who would present with very high blood pressures and pulmonary edema. They would be treated with IV diuretics and IV vasodilators often, would have a short hospital stay and return to home. 20 years later, we took a look at HFpEF patients admitted to Johns Hopkins on our internal medicine services and reported on what this profile of patient looks like. Over 400 patients' charts were examined, and we reported on 200 patients, reporting that the average age was 63, so about a decade younger. Over half women, over half African-American, reflective of our Baltimore population. Majority still with hypertension, but over half now with diabetes, a quarter with atrial fibrillation, relatively few with coronary disease. And importantly, an average body mass index that was 37. And this has only continued to go up since we published this paper now 10 years ago. As you can see, all patients receive IV diuretic therapy, the length of stay anywhere from 6 days on average to longer, and a 1-year mortality of 13%. So an entire change in the phenotype of what has been seen even in our same institution over the course of 10 to 20 years. And this has been nicely depicted by Sanjeev Shah, a thought leader in HFpEF, who's at Northwestern, demonstrating here and showing and depicting here this kind of progression from the hypertensive, hypertrophied LV phenotype of HFpEF to now what we consider to be a cardiometabolic phenotype of HFpEF that is really driven by obesity and cardiometabolic comorbidities. The idea being that a combination of sedentary lifestyle, metabolic stress, cardiac remodeling, aging, and still some component of ventricular vascular stiffening and remodeling leads to a loss of reserve in multiple capacities, cardiac, vascular, and skeletal muscle, and the clinical syndrome of HFpEF. So though both phenotypes are called HFpEF, the nomenclature has not changed. The presentation of the patients is very different, and the treatments, as you will see, in turn is very different. I just want to mention our Hopkins Center of Excellence in HFpEF. For those who are interested in seeing these patients in a more organized and dedicated clinic fashion, I initiated this clinic in 2015. I was actually a trainee at the time. We've now seen over 1,000 patients in this clinic. Over 500 are in our REDCap registry. Our patients all obtain a 6-minute walk test, frailty assessment, coronary artery disease risk stratification, and many go on to get CPET and exercise hemodynamic testing. Unique to our program is that we have an IRB protocol to obtain research endomyocardial biopsies. We have a cohort of over 200 patients in which we have published first-in-human work. So if you have an interest in that work, please feel free to reach out to me or look it up, but we are trying to understand mechanisms of disease. Here's a snapshot of our program. And again, this is really modeled after the Northwestern program, and many programs in the US have now modeled their HFpEF program after us. And I'm happy to speak to this offline and out of the context of the talk. Now, you may be familiar with the concept of phenotyping in HFpEF, and this has been attempted in many different ways: clinical, hemodynamic, imaging, biomarker. This is again from our review from 23, where we basically try to depict that the predominant phenotype today is the obesity cardiometabolic phenotype, and again, increasingly being seen in Asia as well as the Western world. What have we learned from myocardial tissue studies? Well, this was our first report of histopathologic findings from 108 HFpEF patients compared to heart failure with reduced ejection fraction patients and controls. The HFrEF and control tissue comes from a tissue bank at the University of Pennsylvania. These are unused donor hearts, as well as those with dilated cardiomyopathy at the time of explant when those patients are going on to transplantation. And what we have found is that myocardial fibrosis and myocyte hypertrophy, while quite common in HFpEF patients, is mild to moderate in degree of severity in the vast majority of those patients. It is severe in only a very small percentage, as you can see on the panel on the left. Interestingly, 14% of patients were identified to have cardiac amyloidosis on tissue biopsy, and only half of those patients were actually suspected to have amyloidosis. An important point, because there is many now treatments for TTR amyloidosis as well as light chain amyloidosis, and a rare case of myocarditis. When we quantified fibrosis in the myocardial tissue, we found that it was very similar to that was seen in dilated cardiomyopathy or HFrEF. Now, interestingly, fibrosis for many years was thought to be the driving mechanistic factor for HFpEF and stiffness of the ventricle. But as I mentioned, the severity of fibrosis in the contemporary era of cardiometabolic HFpEF is nowhere near what we used to see in the hypertensive heart disease phenotype, as these patients are younger with multiple comorbidities and likely other mechanisms at play. What were the correlates of amyloidosis and HFpEF? Just for the clinicians in the audience who see these patients, those patients presenting with relatively older age, lower blood pressure profile, lower BMI profile, high NT-proBNP, so disproportionate to the comorbidities, and high troponin. So even the smoldering high sensitivity troponin really were all predictors of having amyloidosis in a patient presenting as HFpEF. So please keep those factors in mind when you see a patient coming in who doesn't have the typical comorbidities of HFpEF, yet is coming in with elevated myocardial wall stress markers or a troponin elevation. We have also done a lot of work in hemodynamic phenotyping, and this is just to present a snapshot of our work. we have recently published this paper in JACC Heart Failure. It is now in print actually as of this week, looking at congestion and myocardial perfusion. So interestingly, even though we call this syndrome heart failure with preserved ejection fraction, where the ejection fraction is 50% or greater, and by echo, we presume that cardiac contractility is grossly normal, it turns out, in fact, that 34% of patients in our cohort, this is a study of over 200 patients in our program who have undergone invasive hemodynamic testing, have a cardiac index less than or equal to 2.2 liters per minute per meter squared, and that is by definition cardiogenic shock by the SCAI guidelines. So many of these patients who are presenting to your clinic or being admitted to the hospital, in fact, do not have normal cardiac output or cardiac index with a calculated, novel calculated algorithm, and adjusted and accounted for fit cardiac output as well. And so there are patients who are more low output, more similar to heart failure with reduced ejection physiologically than we would know just from echo alone. All the more reason and importance of hemodynamic testing when it is available. As it turns out, patients who are congested with low cardiac output profile have worse outcomes, and that's for heart failure hospitalization and mortality. And this is a high-risk population that we would call, frankly, stage D HFpEF, which we don't always talk about because we don't send them for transplant or LVAD therapy, but it is a population that is at high risk. I'm now going to pause and segue to treatments. So as you likely know, for many decades, we had no proven therapies for preserved ejection fraction heart failure. Here is a snapshot summary of the many, many neurohormonal agents that were studied and tested in HFpEF patients in parallel to HFrEF. And those shown in red are the many neutral trials which showed no benefit, and in fact, some studies which actually showed harm. However, in the last really 5 to 8 years, we have now seen a complete turnaround in the landscape of therapies, and I'm going to summarize a couple of these key trials. We'll begin with the TOPCAT trial. Now, this is actually relatively old, from 2014, over 10 years old now. TOPCAT, as you may know, was a study of spironolactone versus placebo heart failure with preserved ejection fraction, and including those who were hospitalized. The primary outcome of the study was a neutral outcome. However, what we learned in the aftermath of the study was that there was significant geographic variation in the phenotype and the acuity of patients who were enrolled, particularly Eastern European population with very mild disease, if any heart failure syndrome at all. When the populations were split by geographic variation, the North American cohort and Central American cohort showed a benefit for heart failure hospitalization and a signal for mortality benefit. In the secondary outcome analysis, you can see that there was a signal for heart failure hospitalization benefit. So again, neutral overall trial, but challenged in the enrollment of the study. The Paragon HF study was the first dedicated study of sacubitril valsartan or ARNI therapy versus ARB in ambulatory HFpEF, enrolling 4,800 patients with symptomatic HFpEF, LVEF over 45% with elevated NT-proBNP. Now, in this study, the BMI had to be less than 40. That was actually increased over the duration of the study. It actually began at 35 to actually capture more and more of the contemporary predominant phenotype, with a composite endpoint of cardiovascular death and heart failure hospitalization. And you can see that the study very narrowly missed the primary endpoint here with a p-value of 0.06 and a relative risk ratio of 0.87. But nevertheless, in the subgroup analysis, there was found to be a signal to benefit in those patients who had an ejection fraction below the median in the trial. And the median was around 57% or so. And so in the guidelines, which I'll share shortly, there was an indication that came out in the ACC/HA guidelines to follow for a 2B indication for ARNI therapy in those patients on the lower ejection fraction range. Now, the Paraglide study was a smaller inpatient acute heart failure study of sacubitril valsartan versus valsartan with a primary endpoint of change in NT-proBNP from week 4 to week 8 following randomization. This study did meet the primary endpoint, and you can see the sustained reduction in NT-proBNP with ARNI therapy. I next want to mention SGLT2 inhibitor therapy. As you all know, a lot of excitement around this drug class with really many, many pleiotropic benefits that we truly do not even fully understand. You are likely familiar that the background of this therapy is that these are originally diabetes treating drugs. In the original large diabetes trials, there was a significant benefit noted for ASCVD patients and for cardiac outcomes, and within cardiac outcomes, specifically for heart failure hospitalization. This then led to a series of studies within heart failure patients, both HFrEF and HFpEF, to understand whether that benefit is present independent of diabetes status. The preserved HF study of dapagliflozin versus placebo assessed change in KCCQ score at 12 weeks, as well as 6-minute walk test with a 2 co-primary endpoint, and it did meet the primary endpoint showing benefit for dapagliflozin therapy. Emperor preserved assessed empagliflozin versus placebo with the primary cardiovascular endpoint, and this is actually the first dedicated HFpEF study meeting a primary cardiovascular endpoint in a HFpEF trial. And you can see here, this was not a narrow win. This was a significant benefit seen, and you can see how early the benefit is seen within the first month of initiation with a hazard ratio of 0.79. The 2022 guidelines were to follow, and you can see here, there is still remaining a class 1 indication for the treatment of hypertension. Comorbidity management, of course, is very important. A 2A indication now for SGLT2 inhibitor therapy for patients with HFpEF, as well as a 2B indication for MRA therapy that is based on the TOPCAT trial of spironolactone. And now we have a 2B indication coming down for ARNI therapy, as I mentioned, sacubitril valsartan, and as it says here, and those particularly on the lower end of the ejection fraction spectrum for HFpEF, left to the discretion of the clinician. There is a still class 3 indication that remains from the 2017 guidelines for potential no benefit and harm with nitrate therapy and phosphodiesterase 5 inhibitor therapy, with really no evidence of quality of life benefit, activity or tolerance benefit, and in some cases reporting of worsening of symptoms. Now, following the guidelines, the DELIVER trial was published later that year in 2022. This was a large 6,300 patient study, including those hospitalized with HFpEF and outpatient, randomizing dapagliflozin versus placebo with a composite worsening heart failure hospitalization or cardiovascular event endpoint. And you can see here the study met the primary endpoint, further adding to the strength of data for SGLT2 inhibitor therapies. We now segue to the GLP-1 receptor agonist class. And here this begins with semaglutide, studied in the STEP-HFpEF trials. There was a STEP-HFpEF trial of HFpEF patients with diabetes and without diabetes that were run in parallel. The non-diabetic arm was 530 patients, LVEF greater than 45% with symptomatic heart failure and a BMI over 30. Patients were randomized to weekly semaglutide versus placebo with a dose titration plan, and the primary endpoint was change in KCCQ score and change in body weight. And in fact, both studies, HFpEF, STEP, HFpEF DM, as well as the non-DM arm, met the primary endpoint and were published back-to-back in 2023. This was followed by the SUMMIT trial of tirzepatide, published in New England Journal just this year. 730 patients randomized to tirzepatide versus placebo with a dual primary endpoint. And here we have a cardiovascular or worsening heart failure endpoint, as well as change in KCCQ score. And the study met both primary endpoints. Again, the first of GLP-1 in HFpEF for a cardiovascular endpoint. And again, not a subtle win, significant benefit seen. And finally, I want to mention non-steroidal MRA therapy. This is the finerenone fine arts study that was published in the fall of last year, comparing finerenone versus placebo, demonstrating an improvement in total heart failure events and death from cardiovascular cause. And this was primarily driven by heart failure event reduction with less hyperkalemia and AKI than spironolactone. Though please note, this was not a head-to-head trial to spironolactone. It was compared to placebo. Important to recognize diet and exercise, of course, in HFpEF disease management. This is a disease, as we said, of cardiometabolic syndrome predominantly. There are a number of smaller studies that have showed benefit in exercise capacity, quality of life, peak VO2, 6-minute walk distance. We do not have a hard endpoint trial of lifestyle intervention, but there is an ongoing cardiac rehab study funded by the NIH that is underway that we are part of at a number of other centers in the United States, and we should have a readout in the next couple of years of that study. Finally, just a word on device-based therapies. The CHAMPION trial evaluated implantable PA pressure monitors. This was the CardioMEMS device in patients hospitalized with HFpEF and HFrEF. Interestingly, the cohort that had preserved EF actually derived greater benefit with a reduction in heart failure hospitalization. The reduced LAP 1 and 2 trials evaluated an interatrial shunt therapy. There are now a number of companies that are studying this therapy for those patients with predominantly elevated left-sided filling pressures who have intact right ventricular function without elevated PVR and end-stage disease. We are learning that that phenotype of high wedge pressure, relatively low right-sided pressures may be the cohort that benefits from this therapy, but we still have to learn much from the trials. And finally, the Rebalance trial that was published last year. This is a splanchnic nerve ablation therapy for volume regulation in HFpEF, and it did show preliminary data with a reduction in wedge pressure in these patients, but the primary trial is now underway. So coming back to our patient in 2025, how would we manage this patient? Well, just a couple of years ago, we would focus on blood pressure management, initiate spironolactone, diuretic therapy, and focus on lifestyle interventions. In 25, today, we would continue spironolactone, but consider a switch to non-steroidal MRA therapy. You would continue diuretic therapy. We are very aggressive about adding SGLT2 inhibitor therapy, whether diabetic or not, and consider a switch to ARNI therapy if your patient is hypertensive, especially if that ejection fraction is hovering between the mid-range to preserve range. Certainly adding GLP-1 receptor therapy if they are obese with a BMI over 30, and considering some of the device therapies, and always enrollment in clinical trials if possible. So in summary, the predominant phenotype of HFpEF has shifted to an obesity cardiometabolic phenotype. Diagnostic algorithms for HFpEF remain limited, but often invasive and non-invasive provocative testing can help. Myocardial tissue studies at our institution and others that are beginning to do this are showing distinct genetic signatures, metabolic signatures in HFpEF, and SGLT2 inhibitor, GLP-1 and ARNI therapies are showing benefit for therapy and are now going to increasingly be coming into the guidelines. And finally, we have a lot of promising work happening in device-based therapies. So with that, I thank you for your time. Please don't hesitate to reach out with questions, and thank you for tuning in to this Heart Failure Masterclass series.
Thank you, Dr. Sharma, for a wonderful exposition of the current management of heart failure with preserved ejection fraction. I think the number of patients that we are now seeing through this spectrum of heart failure with preserved ejection fraction is ever increasing. As the age span, the lifespan also is increasing. There are a lot of, unfortunately, I don't think it is we are able to ask questions to her as is a recorded talk. I don't unmute it. So I don't know whether can we ask any questions to her?
I think since it's already 7:30, we should.
No, okay. Thank you so much. Now we'll go to the second part of the program today. That's a case discussion. The case is being presented by students from NIMS Hyderabad, and the student panel is from Sher-e-Kashmir Institute, Srinagar. So over to the distinguished panel of examiners, Dr. Jaganmohan Taragan, Dr. Sudhir Kumar, Dr. Ahmad from Sher-e-Kashmir, and Dr. Srinivas from NIMS Hyderabad. Dr. Srinivas.
Good evening, sir.
Good evening.
Yeah.
Okay, you're not visible. So anyway, over to the examiners.
I now request my students there.
Thank you.
Yes, sir. Yes, sir.
Bash.
Sir, good evening, sir.
Yeah, good.
Good evening, sir.
Good evening. Please wish all the examiners and teachers here, pay your salutations to them and start presenting your case.
Dr. Rathar, welcome here.
Good evening.
Good evening, sir.
Good evening, Sudhir. Over to the examiners, the student who is presenting the case.
Sir, good evening, sir. I am sharing my PPT.
Please introduce yourself.
Sir, good evening, sir. I am Bharat from Nizam Institute of Medical Sciences.
Introduce your team also.
Sir, and he is Raja, sir. And this one is Subhash, sir. Good evening, sir. Good evening. Good evening to everyone, sir. Today I am going to present a case, sir. A 47-year-old female patient.
It is slideshow.
Can you expand the slide or make it only? Yeah, good. Fair enough. Yes, go ahead.
1 minute.
Proceed.
A 47-year-old female patient named exposure resident of the Khammam, who is a daily wage laborer by occupation, presented with the chief complaints of exertional breathlessness since 11 months and swelling of both lower limbs since 2 months. Coming to history of present illness, patient was asymptomatic till 11 months ago. She is a farmer and used to go to a farm which was approximately 3 kilometers away from her home by walk. Her work involved removing weeds, reaping crops, and manually lifting grain sacks on regular basis. She used to work in her field for 7 to 8 hours per day without any difficulty. Around 11 months back, she noticed breathlessness, shortness of breath, which was insidious in onset, occurring after working 2 to 3 hours at her farm, after which she had to take rest. However, over the next few months, it progressed, occurring within an hour of farm work to an extent that she restricted to less exertional work, taking frequent breaks in between, and reduced her working hours also. Since the last 3 to 4 months, she was getting breathlessness even after walking for half a kilometer and stopped working in the fields completely, although she was able to perform activities of self-care without any difficulty. However, since from the last 1 week, she is getting shortness of breath even at minimal exertion like walking for few meters, increases on lying down associated with coughing, and relieves immediately after sitting up, because of which she was sleeping in recombinant position. Hence, she sought medical attendance and was admitted at the NIMS hospital. After admission, she was received some IV medications, after which she had increased frequency of urination and breathlessness subsided significantly. Since last 2 months, she noticed development of swelling of both feet, insidious in onset, initially localized around the ankles, then progressed over last 2 months up to level of the shin. There is no diurnal or postural variation in the swellings. It was not associated with any skin changes. Swelling reduced completely after admission and starting treatment at the NIMS. History of present illness, history of palpitations present since 3 years, which is insidious in onset, regular in nature, occurring at rest, but increased on exertion, which is associated with thumping sensation in the chest and not associated with any giddiness or loss of consciousness. She has no history of any chest pain, no history of loss of consciousness, altered sensorium, or no history of reduced urine output, facial puffiness, or no history of abdominal distension or early satiety, no history of cough with expectoration, no history of pink frothy sputum or hemoptysis, no history of fever with joint pains in the recent or in the past. Next, coming to treatment history, she got admitted in the NIMS for 1 week. After development of breathlessness and lying down, she was started on IV medications which relieved his breathlessness and edema subsided completely. She underwent invasive procedure from right wrist during this admission, likely coronary angiogram. Past history, there was no history of similar complaints in the past. She is not a known case of diabetics or hypertensive. No history of previous surgeries, and not a known case of pulmonary TB. No history of regular intramuscular injections taken in the past for prolonged duration. Personal history, she takes mixed diet with regular bowel and bladder habits prior to the admission, and she denies any addictions with disturbed sleep since 1 week prior to the admission. And family history is nil significant.
No, it's okay. You can stop there. You can ask the SKMS people, just analyze the history and what are the possibilities that come to you. Quite detailed history. I don't know about family history and all getting told, but what do you think?
Sir, 47-year female patient.
No, to the other group. To the other group. To the discussants.
47, so she's a
Discussants.
47.
Yes.
She's a 47-year-old female who presented with history of. She has history of palpitations since past 3 years.
Your interpretations. Interpretations. Yeah.
Okay, and then shortness of breath and swelling.
No,
So
we
just
need not go into repetition. What sir
Yeah.
is saying is you
Interpret
convert it to
the history.
altered physiology. What is the physiologic or hemodynamic abnormality and come to anatomical interpretation of that. That's what sir wants. Rather than repeating, because there are 3 things. One, the palpitation, but most importantly, she has put it very clearly. Excellent history, but need not be that exhaustive. That there is a progressive exertional breathlessness progressing from class 2 to almost class 4 with the symptoms of edema. It's a straightforward history for discussion. That is what Professor Jagan wants.
So it has started with palpitations and then progression of breathlessness from class 2 to class 4, second, which indicates left ventricular failure, and then edema, which indicates right ventricular failure. So what we are dealing here with is a biventricular failure.
No, before that, you need not say left ventricular failure, because we don't have an evidence to say that left ventricle is at fault. But what is the hemodynamic abnormality? When we talk about hemodynamics, what is the abnormality of the hemodynamics? That's the way we used to analyze. Then convert into anatomical and pardon.
As per the history, hemodynamically, as per the palpitations, it looks like either there is a volume overload state, which is then causing,
You don't give too much significance to palpitation because a very non-specific symptom we can be wrong. But the most important symptom is the
there is
breathlessness
shortness
and
of
edema.
Yes,
yes,
breathlessness
breathlessness and edema.
So breathlessness, orthopnea, and edema. So what we can say is that breathlessness, because of, if you consider palpitations in a volume overload state, can explain these things. One. Second thing is that the edema that has developed recently means right heart has been jeopardized.
No, Doctor, sir has been repeatedly trying to bring your attention to the cardinal symptom here, the cardinal symptom being exertional breathlessness and orthopnea. We will attend to the other symptoms later on. First, analyze this symptom of breathlessness for which the patient presented to us in a hemodynamic way. What is the hemodynamic abnormality? Is it a right heart disease or left heart disease? What is happening there? The patient is developing exertional breathlessness in a cardiac patient. Let us assume it's a cardiac cause. So what is the problem there? That's what sir is repeatedly trying to make you understand. And that's what sir also initially Tarkan sir has asked you.
So pulmonary venous
When
condition.
we talk about hemodynamics, what we mean is the pressure, flows, resistance. So that's where you start. So the breathlessness in this case indicates what is the basic abnormality in the pressures. If so, which pressure? It's a relatively simple thing.
It's a left ventricular and diastolic pressure is increased, sir.
Need not be.
Need not be.
Not
Need
be,
not
no.
be.
Need not be. Sir, please.
You
Sir.
say pulmonary venous hypertension,
Pulmonary
will
venous
agree.
condition.
Correct?
Pulmonary venous
Yeah.
condition.
Pulmonary venous hypertension is a basic cause for classical symptoms when progressive. Can pure right heart also cause exertional dyspnea and followed
Yes,
by
sir, it
edema?
can cause, sir.
Yes, it can cause when if there is right heart failure, if there is decreased cardiac output, it leads to decreased peripheral oxygen to the skeletal muscle as well as the respiratory muscle. There is activation of the metaboreceptor in the skeletal muscle. They can cause breathlessness. Even if patient has a ventilation perfusion mismatch also in patient with right heart failure.
Okay, you can be very brief. The low cardiac output can reduce exertional breath. Any other, that is what sir is asking. But before that, I have to say that elevated pulmonary venous pressure need not indicate left ventricular dysfunction.
Yeah.
Yes.
So we'll ask you questions. What are the situations where you get pulmonary venous hypertension without a left ventricular dysfunction? That also you should be careful.
Yes, sir.
Yeah.
Might
You tell that.
in case of mitral stenosis,
Mitral
without left
stenosis.
ventricle
LV
output,
inflow
there is increase in left
obstructions.
ventricle pressure, that can
LV
lead to
inflow obstructions can have these things of different types. But rather than saying mitral stenosis at postgraduate level, it is better to say LV inflow obstruction, classical being mitral stenosis, or some other condition we will ask you. Okay. Then what are the other cause of dyspnea in right heart failure? That is the postgraduate level of
They
answer.
can have the development of pleural effusion. By pleural effusion, they can have ascites that can lead to breathlessness also.
Okay, they can have pleural effusion. This can compromise. They can have abdominal ascites. The diaphragm can go up, restrict the respiratory. But hemodynamic anything else?
Sometimes there is
Hemodynamic anything else? That is what Professor Jagan wants.
Another thing is because of increased RV diastolic pressures, the pressures in the coronary sciences increases that then causes myocardial edema and increases that also increases.
That's one of the proposals.
Okay. All right. I agree with you. Why do you think these patients have pericardial effusion, pleural effusion in right heart failure, but not in left heart failure? Not typical for left heart failure, isn't it? Pericardial effusion and pleural effusions are generally seen in left heart failure, right heart failure,
Yes, sir.
especially pericardial effusion. The reason?
You should know what are the factors, hemodynamics or physiological factors contributing to edema. Edema could be due to, that's the way you have to look at it. If you want to tell that answer, the pressures you have to answer, the oncotic pressure you have to answer, the lymphatic drainage you have to answer. These are the ways you have to handle the question. That is basic physiology you have to handle. That is what Professor Jagan wants.
Yes, sir. So three basic.
Yeah, that's
things.
correct. The venous pressure indirectly also increases the lymphatic pressure, isn't it?
Yes, sir.
The lymphatic drainage gets affected or it becomes compromised. So you can get pleural effusion as well as pericardial.
You can have protein
So
losing.
typically pericardial effusion is not a feature of right heart failure. I mean left heart failure. I don't say that this patient is pericardial effusion. I'm just asking. Of course, as you correctly said, the classical example of a patient with progressive effort dyspnea with orthopnea generally indicates a left heart disease. Isolated primary pulmonary hypertension rarely gives you this orthopneic symptoms, except in very late stages of, as you correctly said, severe right heart failure, right? So generally, we'll put left heart disease high on the card. And of course, you have this palpitation, whether you would like to, at this point in time, give some importance to the symptom of palpitation. It's like thumping, so that may be significant, isn't it?
One more point I want to add to that is, this is more common with the right heart failure because under the pleural effusion is more on the right side. That is what you see. That is because the lymphatics, mainly from the right side, transverses the diaphragm and goes down also. So that interferes. Second, many times in right heart failure, there is systemic venous congestion, splanchnic congestion, loss of appetite, the absorption that is abnormal. They have protein losing enteropathies, so they will develop hypoalbuminemia also. So that also will contribute. Professor Jagan, in early Paul Wood, all those times, it was described that in left heart failure, left-sided effusion is more common, and in right heart failure, right-side effusion is more common. That was one of the things which was described early.
I don't know. I don't. Instead, if it is isolated left-sided pleural effusion, it is not cardiac. It's not.
But one more point which has
either
been
it's
discussed
bilateral or right-sided, then it's called
Right.
cardiac. If it's isolated left, you think for a pulmonary pathology. I mean, that's what we have generally been teaching. I do not know whether there has been any.
I agree with you. One point to say why left heart failure is less frequent is the heart is moving, so it will be squeezing the lymphatic drainage. This is one concept only. There is no proof for that. That is because of the dynamic action of the heart on the left side, it can squeeze the fluid to the lymphatic system. Just a hypothesis, no objective data for that. Okay, go ahead.
Yeah, go ahead.
So palpitation is the next thing.
Do you think palpitation has an importance in trying to tell you whether it's, I mean, what type of left heart disease? Whether it's.
Here you said that the palpitation occurred before the development of symptom.
Correct.
That is
Yeah,
important.
that's the only important
If they
point,
develop
isn't it?
palpitation later in the course of symptom, we don't know whether it's a left ventricular palpitation or a right ventricular palpitation. Stretching too much, but definitely you said the palpitation occurred 3 years back. Whereas the symptom breathlessness is only of 11 months duration. So there your discussion may be relevant. Fine.
Yeah.
Okay, go ahead.
What are the volume overloads of the left side which you might consider explain palpitation? I mean, whatever. It may or it may not be right, but what other things come to your mind?
So regurgitant lesions, sir, like mitral regurgitation.
Aortic regurgitation, mitral regurgitation.
Though palpitations is more common with mitral regurgitation than aortic regurgitation, so we'll keep those differentials.
Okay.
I wonder, whenever it's a postgraduate, we will ask you what is the reference for that. Why palpitation is, because I thought the other way. Because in mitral regurgitation, the volume is not really increased. The systolic and endostolic volume are normal or upper limit of normal in severe even in. Whereas in aortic regurgitation, it's an increase in the pressure load as well as volume load, the largest ventricle. And to me, aortic, I don't know what is Professor Jagan's and Professor Srinivas.
You're right. The bovine hearts are with severe aortic.
Or bovine.
But
yeah,
because I discussed because you
as
said
well
it
as
as
thickness as well as enlargement.
Yes, sir has said, no, see, do you have any reference for that? You have made a very sweeping statement that MR will have more commonly palpitations. In fact, our experience shows and also literature says that AR will have more of palpitations, MR also will have. So that depends upon how much of leakage is occurring. That's all.
Okay.
But you know that if you take the textbook, the common symptom of mitral stenosis is also palpitation. So palpitation is a very, very non-specific thing.
What could be the
that's
reason?
correct.
You will have palpitation on exertion.
What could be the reason for palpitation, mitral stenosis? Sir is saying even MS can have palpitation. What are all the reasons, causes for palpitations in a pure mitral stenosis?
Pure mitral stenosis, most of the times arrhythmic, sir. Arrhythmic, it's because of, say, atrial fibrillation is quite common in them. Here,
Not because of that.
Can
Even otherwise,
can patient with
even
mitral
otherwise.
stenosis and atrial fibrillation have no palpitations at rest, but can develop palpitations on exertion? Can it happen?
Yes, sir.
How? Can you explain that?
With exertion, the heart rate will also increase that
No,
time.
the AF with fast ventricular rate the patient will have palpitations both at rest and on exertion. Maybe it makes much more on exertion, but rest there are no palpitations. Only on exertion, like in a hemodynamic volume overloaded condition, it is happening. How can you explain that?
The point which we discuss is, at our level, we need not spend too much time on palpitation. Our aim is to know whether it is an arrhythmic palpitation or not. That's the most important thing.
Yeah.
So whether a patient has developed an arrhythmic palpitation. If it is not an arrhythmic palpitation, we may spend time to
What
see
I'm
whether it
trying
is
to say
volume
is,
overload.
even
Otherwise,
AF patient,
we are likely to be wrong many times.
what I am trying to say is, even AF patient can have palpitations only on exertion. If their heart rate is reasonably well controlled at rest with your digoxin and other drugs, but they are not good enough to control the heart rate on exertion, the patient will have exertional palpitations. That's one reason. And another reason for palpitations in mitral stenosis patient is a severe TR due to secondary hypertensive TR due to pulmonary hypertension. Okay, please carry on.
The original description was the appreciation of the loud first sound and the thud, which is present, which will be exaggerated during exercise. That was one of the description, but we will not, as an examiner, I will not spend too much time on palpitation other than assessing whether it is arrhythmic or not. But if you are asked if it is present at rest, the thud is more important. It may indicate volume overload. Now, combining that together, which is likely, if palpitation, is it likely to be mitral or aortic? It may not be absolutely right, but what is the dominant symptom? Breathlessness,
favors
high
mitral.
LA pressure. High LA pressure, if it is due to valvular heart disease, it is more likely to be mitral.
Mitral rather than aortic.
More likely to be mitral than aortic. It can occur in both, but this type of presentation is more likely if it is valvular heart disease. Okay.
Okay, let's go ahead. Anything else in the history, like family history and all those things? It's not significant, isn't it? So you're talking about a late onset heart disease. It could still be some of those hereditary cardiomyopathies and also, or hypertrophic cardiomyopathies. I think family history, always you keep it in mind, especially in the history component. Okay. Okay.
So basically,
right.
if you, because it's a interactive session, so we will tell our views also. The dominant symptom is chronic severe pulmonary venous hypertension. The pulmonary venous pressure has gone up and the patient has gone in for systemic venous congestion. That is where we would like to have. Or you can say left heart failure, right heart failure then. So in between, because it is a sequential thing, in between they have to have pulmonary hypertension, pulmonary arterial hypertension. Okay, so we have to say, sir, this patient to begin with has pulmonary venous hypertension, which has progressed to severe pulmonary hypertension and later developed systemic venous congestion indicating right heart failure, which is secondary to pulmonary arterial hypertension, or the basic disease may be affecting both left and right heart in sequence. Then comes the anatomical differential diagnosis. One, you have said valvular heart disease. If not valvular disease, what are the other possibilities? Also, you have to bring in the differential diagnosis. That may be your next slide, your differential diagnosis.
Other cardiomyopathies could be even dilated or restrictive cardiomyopathies.
Okay, which can mimic mitral valve disease. Okay, all the things.
All my cardiomyopathies, isn't it? Even
All
hypertrophic. There's no reason why you.
Hypertrophic also, sir.
cardiomyopathy, that's burnt out
Hypertrophic,
phase.
All types of. That's why I asked you for a family history, because many of these now today we know. You look at the family history; they are all autosomal dominant largely. Whether it's sarcomeric type or dilated cardiomyopathy with skeletal mutations, protein mutations. Family history is important. Okay.
And among the cardiomyopathy, so you have put it as valvular heart disease, then ischemic heart disease, we need not entertain because of absence of all the things. About the cardiomyopathies, which are the cardiomyopathies which over 11 months can go in for severe systemic venous condition or right heart failure, statistically. HCM, the classical HCM, this is the usual age group, but seldom you find patient going for florid heart failure. A dilated cardiomyopathy, in a relatively short time, they will go in for severe symptom. But immediate DD will be among the cardiomyopathies, I may consider restrictive cardiomyopathy. Am I right, Professor Jagan and Dr. Srinivas?
Yeah, I mean, it's possible.
Back in my mind, sir.
Relatively, among
Restrictive cardiomyopathies, you can always bring in some of those infiltrative and storage diseases.
as
Typically,
well as EMF, because
Yeah.
endomyocardial restrictive
Yes,
cardiomyopathies,
exactly.
which can produce the sequentially left heart failure,
Yes.
PH, right heart failure, or it can involve both sides.
both
So
of it
that
can
should
all
come
involve
Also can occur
biventricular.
because of valvular
Yeah.
involvement. Palpitations can also occur because of AV wall regurgitations on both
Yeah.
mitral and tricuspid.
Yeah, certainly. The endomyocardial fibrosis, AVL regurgitation is extremely common.
Yes,
Very rare that you don't have mitral regurgitation or tricuspid regurgitation and you get the right heart or left heart failure. It is rare cases are there. Maybe it will be just 1 to 2% of the total cases.
Some
Purely
people have
diastolic
carried a
dysfunction.
congenital heart disease. Sorry.
At this age, one is atrial septal defect, and CCTG would be another difference.
No, you don't go for very complex things. I think among the congenital heart disease which remain relatively symptomatic and coming at this age group, and not that rapidly oncoming pulmonary vena, but you can just discuss that ASD, sir, in a very diplomatic fashion, because seldom they present with severe left heart failure symptoms. They present with right heart failure, atrial fibrillation, tricuspid regurgitation, but this type of progression from class 2 to class 4 over 1 year is very unlikely in ASD. That's only for completion sake we just asked. Can it be pericardial disease? That's the last question that will be asked.
So, sir, before that,
Because
from natural history point of view, could you consider idiopathic pulmonary arterial hypertension with this history profile?
Young patients.
Actually, the law, I mean, as I said, that's why I told you, effort dyspnea, always you should think of primary pulmonary hypertension. Pulmonary arterial hypertension. But subsequently, the symptoms do suggest that it's probably more of pulmonary venous hypertension with orthopnea.
Sir, my question is to them, sir, students.
I just asked. I thought I'll just.
they didn't answer immediately.
Yeah.
Because we want to save time. If they don't answer within 5 seconds, we'll answer. So that we can go to the next thing. Because it is they have to answer immediately.
Sir is asking whether it could be pericardial pathology.
Yeah. Can it be pericardial disease? This is the way we ask questions. And you should know also.
Could be, but
yes, no.
There would be right-sided features would be more
likely or unlikely, sir. It is unlikely. Because severe symptoms of pulmonary venous congestion, then progressing to systemic venous congestion is very unlikely because the classical CP presents with the involvement of both sides of the heart. So that is unlikely. Primary pulmonary, I also agree that we have to discuss that. But once primary pulmonary hypertension develops this much of symptom and right heart failure, they are less likely to show a dramatic improvement with diuretics. You said that was an important thing in your history. Don't say the patient passed the urine, all those things. You can say produce diuresis. Okay. So you say that the patient was admitted in ICU with diuretics. The patient showed a good symptomatic improvement. Is very unlikely to be idiopathic pulmonary hypertension, which has gone in for severe cardiac failure. So their symptom of low cardiac output will dominate. Because pulmonary arterial hypertension will have low cardiac output, and once they go in for cardiac failure, they will be in very bad shape because they have gone for edema. So naturalistically, I thought it is.
That's why I have
specifically said
that. Naturalist, sir.
You have to discuss that low in the list. Everything you have to discuss and put it in the order.
So what is this? To summarize from the history, and we'll move forward. What are the important differential diagnoses you have considered with this history in this patient?
The first thing is
next slide.
Valvular heart disease.
No. You have to tell what is the first possibility.
AR. First possibility.
Sir has told you, is AR more likely to cause exertional breathlessness without assuming she didn't develop LV dysfunction, systolic LV dysfunction? More likely to be regurgitation.
Then MR.
But why are you so much fixated that MR doesn't cause much of palpitations? No, I think they said MR only causes palpitations. So don't go into palpitations thing. The pulmonary venous hypertension is the crux of the issue here. AR is more likely to cause, or MR is more likely to cause. So first possibility should be severe mitral regurgitation.
Severe mitral regurgitation.
Then
Then we'll go for AR, sir, aortic regurgitation.
Next
That's
slide.
the-
Okay,
Next
so
slide. There.
valvular heart disease, either mitral or aortic,
Either mitral
predominantly
or-
regurgitation conditions. Okay, any other condition you think of? Like myocardial disease you're considering or you're not considering?
Yes, sir.
From
Myocardial
history
disease-
alone.
Your next slide. It was the different diagnosis you had.
Okay, sure.
Next slide. Okay.
Okay. Oh, you thought of restrictive against ischemic. Okay.
Regarding the valvular disease, preferably I prefer to say mitral valve disease rather than saying mitral regurgitation or not, because it could be mixed mitral valve disease also.
Yeah, that's
Could be
So it
mixed
is
up.
better put it as mitral valve disease.
Something
And probably
has one of
dominant
them
MR.
could be more dominant.
Dominant MR.
It could mix it.
Okay.
Yeah, agreed.
Then it will cover the whole thing. The concept is there. Aortic valve disease low in the list because they have come with severe heart failure. It will be very, very what you call when they go in for right heart failure. Aortic valve disease, it is relatively less common compared and doesn't show dramatic improvement with diuretic. Dramatic improvement with diuretic indicate that the venous congestion is contributing predominantly with a reversible component. That is, the myocardium is not that bad. Okay, fine. Can we go to the physical findings?
Yeah, I thought so.
I think the historic discussion, I think we have considered chronic progressive pulmonary venous congestion, progressing to severe pulmonary hypertension, pulmonary systemic venous congestion, and likely to have significant pulmonary hypertension. Regular rhythm probably may indicate the patient still is in sinusrhythm, but be careful. Be careful because by this time, if it is mitral valve disease, if it has progressed to congestive heart failure, most likely they will be in AF statistically. So don't give too much significance to that palpitation for analysis. Okay. Then, as you have said, mitral valve disease equivalence. That could be inflow obstruction and something which can mimic mitral valve disease, cardiomyopathy is restricted cardiomyopathy, dilated cardiomyopathy. Because the patient has gone in for congestive heart failure without the classical symptom of a hypertrophic obstructive cardiomyopathy, we may not. In restrictive cardiomyopathy, we have the classical diseases involving the myocardium, including HCM phenotypes also. Okay.
We'll go with the examination, sir. We already it is 8. We have to finish by time. So please, Dr. Bharat,
Sir,
go ahead with your presentation.
coming to general physical examination, sir. Patient is conscious, coherent, and cooperative, sir. Well built, well nourished, with height 155 centimeter and weight 65 kg, BMI around 27.1 kg per meter square. And no palor, icterus, cyanosis, clubbing, or lymphadenopathy. With bilateral pedal edema, which is of pitting type, extended up to the shin. And pulse is 80 beats per minute, which is regular, high volume pulse with no radial delay, no radiofemoral delay. And our peripheral pulses are palpable. And the BP is measured in all 4 limbs. In right upper and lower limb. Right upper limb it is 110 by 50, and left upper limb it is 114 by 50, and right lower limb it is 150 mmHg systolic, and left lower limb it is 154 mmHg systolic. And respiratory rate is around 24 per minute, which is a thoracic abdominal type. And patient is febrile with saturation being 94% in all 4 limbs. And there is a Hill sign present, which is around 40 mmHg on peripheral signs. On examination of BP.
Yeah, go ahead.
Next, coming to systemic examination, CVS examination. JVP is 7 centimeter above the sternal angle in 45-degree inclination with a prominent A wave with the normal distance. And on inspection and palpation, chest is bilaterally symmetrical and trachea is midline with no scars, signs over the chest and no tenderness, and with fullness of intercostal spaces. And apex is located at 6th intercostal space, approximately 1.5 centimeter.
I will intervene because I may forget. Because certain things we have to, JVP always put it in sitting position. At postgraduate level, sitting position, that is enough. Even for a routine practice, that is enough.
Yeah,
second
sitting
thing,
position with the legs hanging down.
That should be the standard method.
Standard one, and if it is visible, then your suspicion that the JVP may be elevated. It can be just prominent A waves, but for A and V. But the mean JVP, of course, it's only an interpretation. It's basically you can't really tell it mean JVP. But if the patient is relaxed, sitting, and if the JVP is seen above the clavicle, then it's likely to be elevated, right? And how much is it equal to in millimeters of mercury at the RA?
5
JVP
and
seen
then
at the clavicle in sitting position would equate to what pressures in the RA in millimeters of mercury? This is centimeters of water.
15.
Just simple question. I mean, you can go forward.
Okay, that's important because that's the question which we ask. Hemodynamics is the important thing. What is the normal RA pressure? And up to this level, it could
Yeah.
be upper limit of normal RA pressure.
What is the normal
Second,
RA mean pressure? And how much it would be if it is 7 just at the clavicle?
7 plus 5.
I mean pressure around 5, more than 5 should be taken as abnormal, mean pressure. So this would be 5 plus 5, 10, isn't it? Sitting position from the right atrium to the clavicle would be 10 centimeters. 10 centimeters will be how many millimeters of mercury? Divided by 13.
1.36.
Okay. 7. Yeah, 7 millimeters of mercury. So it is highly elevated. Certainly, it is a little disproportionate to the pedal edema that you had told. What do you think it is due to?
Diuresis, sir.
Surprised the
They have given
JVP is only
diuresis.
just visible at the clavicle? Patient has been diuresed, isn't it? You yourself said that the patient has. Okay, go ahead.
Okay, again, JVP, if the jugular venous column is not visible in the sitting position, or if it is only borderline elevated, you have to do the abdominojugular reflex and the respiratory variation. That you have to mention. Because then you have perfect presentation. That is, jugular venous pressure is elevated in the sitting position. In borderline, you have to go for abdominojugular reflex. Second, respiratory variation you have to mention. If the JVP is not visible, you can put in 45-degree position to see the waveform. So everything is important, but sitting position, if it is visible clearly, don't put in 45-degree position. If it is just seen, then, and you are seeing only some waves, do abdominojugular reflex to identify the wave pattern. And whether the abdominojugular reflex, you know, it's not the rise which is important. It should fall immediately in the next 3 to 5 cycles. Normally it rises, but it should not be sustained. RV dysfunction, sustained elevation. That's more important. The second thing is that fullness of intercostal spaces is an unfamiliar thing for me. These are the things which you should avoid. Unless it is very important, you need not bother very much, especially in our examination. Chest is symmetric, no scars or this thing. No tenderness, not needed in this case. So you can reduce the presentation by coming to relevant points. And fullness of intercostal space, I don't know. I don't want to stretch that discussion also. Apex beat in the 6th left intercostal space. Go ahead.
Apex beat in the left 6th intercostal space, 1.5 centimeter lateral to mid-clavicular line, occupying 2 intercostal spaces, which is hyperdynamic in character, and no apicocarotid delay, and carotid thrill is present, no parasternal heave, and no palpable heart sounds. Coming to percussion, left heart borrowed corresponds to the apex.
Just I want to ask some questions which I may forget. What is the importance of apicocarotid delay? And what is it? Now the questions will be there. What is the importance of this apicocarotid delay? What you are looking at? Which phases of cardiac cycle? It's an important thing because when you say clinically apicocarotid delay, it's difficult. When you are recording it, you can correlate certain things. Because apex and carotid, what you are palpating, there are different phases and there is a lag also. So it's not an easy thing. Okay. So be careful because people like Professor Jagan may go into the details of that. I also may go into that details of that if time permits.
Clinically very
to
difficult to appreciate, so I usually
pick up a good student, that is the cardiac cycle and correlation with the carotid pulse. What is the time delay?
If they know the mechanism, what is the normal apex beat related to which part of the cardiac cycle and carotid which part of the cardiac cycle, it'll be good enough. And obviously there should be a delay. What is the delay called?
Delay is around 30-35
No, what is that? What is the period? The delay.
That's the thing, cycle, cardiac wise.
In cardiac cycle, what is the delay between the onset of the apex beat as well as the onset of the carotid?
Are you looking at the onset of the apex, onset of carotid? These are the questions. It is a little difficult for you. If you answer, you will get bonus marks. That's the problem. So avoid that. You avoid that.
Yeah.
Okay. Carotid thrill present. There again, you should be careful when you say carotid thrill. Now we have to say there is no precordial thrill, and the carotid thrill important is it carotid shudder or
your
not?
apex is hyperdynamic in character. It is irrelevant to mention about apicocarotid delay.
Yeah, that's correct. It's basically yes.
It's when you have a sustained and heaving apex where the lesion is a dominant valvular AS, perhaps then there is some meaning in talking about that. When your findings, all other findings are also already pointing towards dominant AR here, there's no point in talking about apicocarotid delay. So this is the kind of criticism and questions that you would be inviting from the examiners.
So that fullness of intercourse space you have to delete. Epicocarotid delay you have to delete. Because what we are interested is there a slow rise in the pulse? You have said the pulse is high volume and collapsing. So don't bring in confusion. So
Sir,
we'll
they
be
are not
rating the
mentioning
students
collapsing, sir. That is what I was about to ask them. They said there is a hill sign of 40. Perhaps you would like to discuss that later on once that presentation is completed. 40 millimeters of mercury hill sign is there, but only high volume pulse was highlighted with no mention about collapsing.
Oh, no.
That is
go ahead.
unusual here. Okay, go ahead.
Go ahead.
On percussion, sir, left
Percussion,
water is
okay.
yes. Yes, on auscultation, S1 is soft and S2 is with narrow split with soft A2 and LV-S3 is present with no additional hard zone.
What about P2? Its intensity.
So second zone, we are interested in P2.
Yes, sir.
When you say a soft A2, you are comparing. And we are interested in P2. If the P2 is loud, A2 will be relatively soft. But we are interested in P2.
Because
we seldom concentrate on A2.
Historically, we thought of pulmonary venous hypertension being the hemodynamic problem here. So you should talk about the intensity of the P2 and what is your impression about P2. That is very important. Soft A2 alone doesn't mean anything here. Narrow split, agreed. So split is there. So you made out the split. That means P2 also is made out. Then what is its intensity? And if you think it is normal, with respect to a soft A2, how would you say it is normal? With respect to soft A2, again, how would you say it is increased? You understand my question? Okay, please carry on.
There's no mention of the pulmonary component at all. I think you should make a mention because you are able to hear the split. Anyway, I think
we are anticipating pulmonary hypertension because the pulmonary venous pressure has gone to around 20-25. So PA diastolic pressure has to be at least 25 or 30. Even if you take the transpulmonary gradient as normal, if the pulmonary artery diastolic pressure has to be around 30. So we are interested in P2. Even hemodynamically, we are interested in P2. Okay, that's the important thing. Okay. Now, when you're talking about AR, you may argue, sir, I am interested to know what is the mechanism of that AR. So soft P2, I am interested in a valvular AR rather than a vascular. But that's not the important thing. The important thing is hemodynamically, pulmonary component is important. Probably anatomically, A2 is important.
Yes,
so, but we are interested in hemodynamics. Once you have said LVS3, don't say no additional heart zones or no other additional heart zones.
Yeah, what all you specifically looked for? No ejection click, probably aortic ejection click you're looking for if it is dominantly aortic varices. Or an opening snap if you think it is a rheumatic origin of the mitral valve. So these things you should just specifically say because that tells us that you have thought of these things. Okay, so in presence of soft A2, a P2 may be assessed by going away from the pulmonary area towards the lower sternal H2 apex. And if still you are able to hear the pulmonary component, then you will assume that pulmonary component is loud.
Yeah.
Except
irrespective of the A2 intensity, A2 is loud.
Yeah, it's all theoretical. I don't think I myself would be able to appreciate all this. But somebody asks, you may
have an answer. Defend yourself.
Okay.
Okay.
So clinically, what sir said is important. If you can hear both the components over the apex beat, then the P2 is accentuated. Okay. Second, anticipate that this patient has pulmonary venous hypertension, so PA pressure is likely to be high. So if you are hearing the second component louder than the first component, more likely the P2 is louder rather than A2 soft. That's the statistics. So it's very simple. Second thing, we are interested in P2, not in A2 in this case.
But he's
Unless
it
is an isolated aortic regurgitation
aortic valve is diseased
without pulmonary arterial hypertension, to know whether it is valvular AR or vascular AR.
Agreed, A2 will be softer in this patient because of aortic valvular disease. As we all have been saying, intensity of P2 is more useful here for clinical prognostication as well as severity grading. Please carry
So
on.
you have the apical pansystolic murmur of mitral regurgitation because to save time, and you have the early diastolic murmur of aortic regurgitation, and the most important question will be on the third murmur. Okay,
So
so
grade
that's
3
the
by
way we proceed. Okay, go ahead.
grade 3 by 6 high pitched soft blowing pansystolic murmur head at the apex radiating to the left axilla, which is better head in the left lateral position with diaphragm at end expiration, which is increased with hand grip. And next, grade 3 by 4 high pitched soft blowing decrescendo
There
early
again,
diastolic.
when the patient is in heart failure, the dynamic auscultation has lot of limitations, and we need not do. Okay, but in very specific situation we may do. But when the patient is in heart failure, we are not supposed to do that. Number one. Second, the hemodynamic changes will not be that appreciable. That's a basic thing. Okay, fine. Go ahead.
Grade 3 by 4 high pitched soft blowing decrescendo early diastolic murmur better head at third left intercostal space with diaphragm in leaning forward and end expiratory position, reaching up to later 2/3 of the diastole and it is increasing with the hand grip. Grade 3 by 6 high pitched harsh crescendo decrescendo ejection systolic murmur with early peaking better head at right second intercostal space in leaning forward position occupying initial 1/3 of the systole, ending well before second heart zone, radiating to both carotids, best head with the diaphragm at end expiration and not affected by hand grip.
Okay,
Fair enough. Yeah.
other systems are.
Other system examinations, respiratory system, bilateral air entry is equal, normal vesicular breath sound, bivesicular fine crepitations are present, and per abdomen examination is not distended, no organomegaly and no tenderness and no rigidity. Neurological examination, no focal neurological deficit.
You have to look at the
Stop
fundi.
here.
We have to look at the fundi. Make it a habit to carry an ophthalmoscope, because fundus is important. Probably the patient may have hypertension, you may be dealing with some other disease, you may be dealing with atrial fibrillation, and AR also they may ask, what are the ocular findings of AR? Okay, always, at least during your course, at least you should see at least 10 cases, you should have the retinal examination by the ophthalmoscope. And because you have to do that in the examination, we may ask you to demonstrate, it should be systematic. So make it a
MD
habit,
level,
because
everybody brings
none-
a ophthalmoscope. At DM, nobody brings. That's something. But it doesn't matter. But I think it's very important. It's
an
a
important
clinical
thing.
finding, isn't it? Which if you pick up, you get credit for that. Okay.
Because I have not seen postgraduate doing this exercise.
That's
And
correct. That's what I'm
examination,
telling you.
that's important. At least sometimes, so for example, hypertension, we'll ask you, is it hypertensive, we won't use the term malignant hypertension now. Is it severe hypertension? Is it end organ damage, hypertension mediated organ damage? So retina is very important. The patient may be having a valvular heart disease with fever, maybe endocarditis, or may not be. Have you looked at the fundi? You cannot send all the patients for ophthalmologist. So make it a habit, because I have not seen postgraduates during their PG training, how often they are they have used this thing. Make it a habit. Okay, very important. Some examiners are very fond of this. Okay, and it is important clinically at bedside also. Okay, go
Analyze
ahead.
the symptoms, the examination findings, the other group. We have only 15 minutes now.
In the
Okay.
examination, there was a high volume pulse, first of all, and then there was Hill sign present.
Systolic decapitation.
And then there was the systolic pressures were not that high as they should have been in AR. So there was some systolic decapitation, we could see.
Yes. Good.
Then, sir, then the apex was hyperdynamic, and and it was downward and outward this deviation of the apex. Then
Do you think, are you okay with these findings which you have just now enumerated? Are they all in sync with each other, or do you think there is some kind of discrepancy in the findings? We are only analyzing what is given to us. So,
More favor of
you
AR,
are-
sir.
these things.
You see, there is
Hypertonic.
systolic decapitation, you said. What could be the reasons for systolic decapitation in a patient supposedly having severe AR?
Or in this case, what is the cause for, or what are the causes for systolic decay? I have given you the clue.
So one thing.
What
so
are
one
the
thing is
causes?
One is LV systolic dysfunction.
Yes,
Yes.
good.
Systolic. So second thing is AS. If there is
AS,
associated
significant AS is there. That's correct. So decapitation, if there is this, and anything else?
So severe MR again.
MR, associated MR.
Severe proximal valve disease, isn't it? Severe
Proximal
proximal
valve
valve,
disease.
which can be also another cause for low cardiac output. So it's not only left ventricular dysfunction. If there is proximal obstructive regurgitation lesion with LV dysfunction also, you may get a decapitation. Yeah. So what about that S3?
With right
Do you
heart
give any
failure.
importance to S3? I think it's very important, no? Because yes,
S3 usually in AR, S3 is not seen. If there is S3 in AR, either it is LV dysfunction or associated MR, sir.
okay. Now in the setting of aortic valve disease, what does S3 tell you? Quickly.
Severe aortic regurgitation.
LV dysfunction, associated LV dysfunction.
Associated LV
Associated
systolic
LV
dysfunction.
dysfunction.
Yes, either acute AR, which of course is not the case here, or severe AR with LV dysfunction. So some books do mention that severe AR itself can cause a third heart sound, but generally you should think of these two first, and then of course severe AR. All right, then if there is mitral valve disease also?
Yes, sir.
Yes, sir. Associated MR can also give us S3.
S3. If there is associated MR, it can also be valve.
You would have expected an MDM because you have got both AR and MR. A mitral regurgitation and a mid-diastolic murmur could be due to what are the reasons you might get a mid-diastolic murmur?
Yes, sir. Flow murmur related with this thing. Severe MR could give us MDM.
Yes, flow murmur related to MR. And what about the AR? What's the cause or mechanism of that so-called DM or whatever you want to call it?
Austin Flint
murmur. Yes, what's the mechanism?
There are multiple mechanisms. Sir, the AR jet is striking with the MR jet. It can cause turbulence. It can lead to this and fluttering of the
either turbulence or a sort of reverse doming in diastole. Okay, mitral stenosis is a standard doming. In AR, it is a reverse doming in diastole. So that also causes some relative mitral valve obstruction. So the two things. And the other one is maybe the vibration. If
And
the
LV
AR
dysfunction, LV diastolic pressure going up. LV dysfunction, LV diastolic pressure going up, and diastolic mitral regurgitation also you have to discuss. But the issue which we will discuss is if there is MR plus Austin Flint, what will happen to this mid-diastolic murmur? I will leave it to Professor Jagan Mohan to discuss with me later. Okay, because there are two mechanisms, one regurgitation and or this thing. Okay, forget about that. So you should have said there is no apical MDM.
that you should have told. Because it's extremely important, isn't it?
Yeah. Yes. That's an important thing. You should have said no additional sounds. Sir, all these murmurs, there is no mid-diastolic murmur or apical mid-diastolic murmur. That means
both your regurgitation lesions can actually cause some mid-diastolic murmur at the apex. Okay. So let's go to the next.
Your final diagnosis.
Yeah.
Final diagnosis being it's a valvular heart disease, probably of rheumatic origin with severe aortic regurgitation, with mild aortic stenosis with moderate mitral regurgitation, likely in sinus rhythm, NIHA functional class 3.
No. Likely sinus rhythm, you are irritating me. Why do you want to put this likely sinus rhythm? You have said normal waveform, prominent wave, regular rhythm. There is no different diagnosis clinically. I don't know. So these things you should avoid. Second thing, aortic stenosis is you have, according to your findings, it is not there. So you do not bring it there. Let us ask. So things which are very solid, you should say.
You yourself said early peaking and limited to the first 1/3 of systole. I don't know what murmur you heard, grade 3, but don't be too exaggerative in your findings. I agree with you if you say it's an early peaking
and he said early peaking short murmur.
Which does suggest that, and not going up to the second heart sound or stopping well short of the second note is fair enough. Say that it is probably not a significant aortic stenosis. Then what is it likely to be? That murmur is likely to be?
Ejection flow murmur.
Again, ejection flow murmur associated with severe
there is AR, isn't it? So it can be a flow murmur. that is why it's important to know whether, as Sudhir Kumar telling, whether it was a valvular lesion or a iotopathy. Iotopathy with aortic radiation, you don't get a flow murmur of systolic murmur because the aorta is very large, aortic root is large. But in any other, whenever you suspect mild aortic stenosis, only three differential diagnoses: rheumatic, congenital abnormality of the aortic valve, and of course degenerative aortic valve. Right? But iotopathy has so many differential diagnoses, but they will not have aortic stenosis. Okay, that is the importance of isolated AR against ASIR or ARS. Okay, let's go ahead and.
So you have to put it as multivalvular heart disease, probably of rheumatic etiology, aortic plus mitral valve disease, aortic regurgitation severe, mitral regurgitation don't modify or put the severity because it's a very difficult thing in a combined lesion. So need not straight away put the put questions to us. That is likely you should avoid. It is normal cynosism because everything in favor of cynosism, all the other things agreed. No signs of infective endocarditis. Status post coronary angiogram you need not put. So he underwent a coronary angiogram. That's not a part of diagnosis. There is a procedure. So diagnosis should be valvular heart disease, congestive heart failure, biventricular failure, or congestive heart failure. Okay, you have to substantiate this. Severe AR, I think we need not discuss because there is a wide pulse pressure, low diastolic pressure, left ventricle, all those things. The murmur is long, everything. But what happened to the murmur when the patient develops LV dysfunction?
Does this patient
That
have
is one
LV
thing.
dysfunction? First, I would like to answer that question. Patient has in left ventricular S3. To what do you attribute this left ventricular third heart sound? Is it to the left ventricular dysfunction due to chronic severe AR? Or is it due to hemodynamically significant mitral regurgitation? You see, usually, as Sir also has said, the presence of an LVS3 in an isolated severe AR, we usually consider that as an evidence for clinical evidence for left ventricular dysfunction. In that case, you expect the apex to be become sustained, not only to be hyperdynamic, down and out, and it becomes sustained. But that is not the apex here. So,
yeah,
if you think ST is due to mitral regurgitation, if you think ST is due to mitral regurgitation, then mitral regurgitation should be necessarily considered as severe MR. So this is how your thought process should go. So the correlation between the presence of left ventricular third heart sound and a hyperdynamic apex extremely is useful here in this patient with severe AR and some degree of MR. You want to know, quantify the MR, then if the apex is truly hyperdynamic only and ill-sustained, but there is unquestionably a third heart sound that should be attributed to the mitral regurgitation, and in which case it should be severe.
There is a question in the chat box. In the chat box.
I'll just tell you, mechanically we tell that apex beat is hyperdynamic in AR, MR, and VST. Actually, hyperdynamic is truly only for MR and VST, not for AR.
Yeah.
AR has got both pressure and volume overload, so you always will get a little of a little heaving type of this one. But people are reluctant to write a little sustained and heaving.
Because I don't know, sir.
But I'll tell you, if you put your finger there, you
so ingrained in so it is so ingrained in the minds of the students that AR is only a volume overloaded condition. So, in spite of the,
this is a problem with the candidates. They always will tell it is hyperdynamic. But
there is a question in the chat box.
See, in hyperdynamic, the LV is not thickened and thickened, hypertrophic. In AR, it's not like that. LV is hypertrophic. Okay.
There is a doubt raised in the chat box.
It's a multivalent disease. I think in Indian setting, in a 47-year-old female, it has to be rheumatic, isn't it? In the West, of course, in a little more elderly, you think of only degenerative valve disease. For whatever reason, aortic stenosis, aortic irritation, and valvular mitral. But in India, I think in the absence of even a history of rheumatic fever, probably comes.
Can we move forward? I think we are a little running short of time.
So I guess it was finger.
Shall we go to the next?
We should get by the scheduled times.
Okay. There is a question in the chat box. I think we have to address that also.
Yes.
NEA, or if there is LV failure, how will you explain the wide pulse pressure? That's a question. Okay. But that is relative. That is relative.
Decapitation is important. You might still get a little wide pulse pressure, except, in acute AR, yes. Because LVDP rises markedly. But in chronic AR, you might still get a low diastolic pressure in AR. But decapitation will be more important.
So AR produces low diastolic pressure. Systolic decapitation is more important in chronic AR with heart failure, systolic decapitation. Because the systolic performance is affected. The diastolic performance is not affected.
Not
Whereas
so
in
much.
acute AR, it is entirely different. Okay,
Yes.
next slide.
Okay.
Dr. Venu, how much time we have? Because we started 15 minutes late.
Yeah. No, we can have
No, sir, we didn't start 15 minutes late, sir. We started.
8:45.
No, you tell us when to stop. We
You
will
tell
just
us
stop.
when to
Okay.
stop.
Let's go
8:45.
quickly over the electrocardiogram. We will not.
Another 10 minutes, I think we can have.
Yeah.
Coming to investigations, it's a
Division.
standardized 12 lead ECG with normal sinus rhythm.
Because
The
to
rate
save
around-
time, the contribution of the ECG to your diagnosis. Does it favor your diagnosis? That's all. Because all the other things you should know. Is it favoring your diagnosis, severe AR?
It's favoring severe AR, but in addition, there is a
LVH
component
strain
of
pattern, strain
the LVH is not that much proportionate to AR only. They say
No, it is
according to
proportionate.
Sokolow.
The point we are
They
telling
say-
is it is proportionate because the voltages very tall or the voltages is the thing which indicate LV dimension. There is a very tall R in V5, V6, deep S in V1, V2, and axis is more maybe minus 30. So that favors a large left ventricle. The larger the large ventricle occurs with severe AR. That is a condition where you get, I think some people use the term core
Yeah,
bovinum.
that's correct.
The largest heart is in AR. Whereas in MR, even with heart failure, the ventricle will not be significantly dilated. So this favors. The STT changes doesn't favor aortic stenosis, but any patient with the LV volume overload, when they go in for LV failure, the LV diastolic
That
pressure
time
goes up. There is
yeah.
subendocardial ischemia, and you can have secondary STT changes.
That's
So this,
correct.
I think all of us, I think Jagan is agreeing with me that
Yeah, you're
this
right.
goes
The
for severe
presence
AR.
of Q wave, a large voltage is AR against AS, right? Now you'll ask you why ST changes. ST changes only when AR is leading to,
When they develop,
for whatever reason, subarachnoid
LV
ischemia.
function.
And there is some sort of disparity between the limb leads and the chest leads. You would call the limb leads as low voltage, isn't it? So that also you must think of ventricular dysfunction. Right?
There is some
See
widening
the
of the QRS.
standard limb leads, they're all less than 5 millimeters.
What is the width of the QRS, doctor?
100 milliseconds.
Pardon? QRS duration.
80
Around
milliseconds.
100 milliseconds. Am I right?
Yeah,
Yeah,
right.
okay. Answer that question.
Is it widened or it is normal?
A bit,
It's normal, but
it's between 100 to 120. No?
Okay, right.
1,
Okay.
2.
It didn't look very
somewhere around
wide.
110.
So, of course, there is LA enlargement also, but
Yeah.
not again very typical. But still, I would suspect that in the setting of AR and this type of LV, LA enlargement also is there. Right.
So mitral regurgitation also may be significant.
There,
It may
MR is there.
suggest LV dysfunction.
Significant MR
Okay.
is there.
The limb lead voltage can occur when there is generalized edema. If the patient has gone in for heart failure, the
Yes.
limb lead voltages can be low.
That's
So
correct.
it was when was it taken? When the patient had significant edema or when the edema cleared? Okay, next slide, because we have only another 3 minutes.
Yeah.
Okay. There is cardiomegaly everything. That doesn't help us. But what are the things you're going to look for?
See, all along we have discussed about pulmonary venous hypertension.
Yeah,
Please,
that's
is the X-ray showing pulmonary venous hypertension? It seems to be quite dark. Lung fields may be overexposed, or when digitization conversion is done, resolution has suffered. I don't know, but there is not significant pulmonary venous hypertension. That's what we are interested to look for. And pulmonary size of
also.
pulmonary artery is easy to dilated, because you have not told anything about the intensity of the P2. So we would like to see the evidence of pulmonary arterial hypertension from X-ray also.
Look into the LA for assessing the severity of MR. Because we are not sure about the severity of MR because the findings are overlapping. So that will be very useful. The LA is not grossly enlarged. So unlikely to have
All the
severe
three
MR.
are, sir, as you said, all the three are related here: pulmonary arterial disease and LA enlargement and pulmonary venous hypertension. All these three things
Yeah.
which show significant MR is there. But we can't say whether there is still significant MR or not. From X-ray, we cannot say.
That's correct. I agree with you. Yeah, obviously this large heart. I think that below the main pulmonary artery is that the LA enlargement, that LA appendage is the one which is seen, which gives you a feeling that it's all rheumatic, whatever mitral regurgitation or mitral stenosis. I would vote in favor of pulmonary venous hypertension because though some of the lower lobe vessels are masked by the heart, but pulmonary venous, the prominence of
Right side, yes, sir. Right side, I think. Right
and
upper
there is a
zone.
right effusion.
Right upper zone.
Yeah, that's a point which I want to highlight. There's a right
And no
side
calcification of any valves that you see. So these are the things I would try to say, okay.
and right atrium is dilated. So that also the right atrium is dilated. There is a right side pleural
Yes,
effusion that
right
goes
atrium
in
is
with your
certainly
diagnosis of systemic venous congestion or right heart failure. I also agree with both of them that this is a little overexposed, so pulmonary vasculature gets attenuated radiologically. But
Yeah.
I also feel that the upper lobe vessels are seen, but not the lower lobe vessel.
Exactly.
So I also feel there is pulmonary venous hypertension and systemic venous hypertension. Right atrium is also large.
Right atrial plus maybe the SVC also.
Yeah.
Okay, let's go to the echo quickly.
Can you show? Yeah. Doctor from Kashmir, please start talking about the echo. Read the echo as it is run. Tell what is this view?
So parasternal long axis view, sir.
Yeah. You tell what are the structures you are seeing. Everything you just.
So parasternal long axis view is we see LA, LV, LV, OT and aorta, proximal portion, and we also see RVOT, sir. Here LA diameter, if we compare with the aortic diameter, it is enlarged, sir. Ratio is more than one. Second, there is doming of.
Yes, go ahead. Go ahead. You are right.
Second thing is,
You are in the right path. Go ahead.
Yes.
So PML is fixed, sir. And there is thickening of the valves, both mitral valve as well as the aortic valve.
Mitral valve finished. Mitral valve apparatus we have to talk. Not only the leaflet.
Is
We have
it
to talk
thickened,
about
sir?
the AML doming. PML is thickened with
PML doming
restricted
is there.
mobility. There is a subvalvular thickening also. Okay, but it is separating fairly well.
Yes.
Aortic valve you cannot
Diastolic,
clearly see.
diastolic separation of the mitral valve leaflets is quite good.
It's good.
Can't be more than mild mitral stenosis. Yeah. Let's see. LV function looks good.
Left ventricle is not grossly enlarged. Left ventricle is dilated.
Yeah.
This is the parasternal short axis taken
The
at the
dimensions
papillary
maybe
muscle
at
level.
least 7 centimeters. And systole maybe around 5. I don't know what. Do you have the readings? Then you can tell us quickly. But the function is good.
Obviously, with this type of frame, you cannot talk about the contraction and wall motion because it should be a continuous thing. Then only we can visually make an assessment. Next one.
Okay, tricuspid
Aortic
leaflet
valve.
with mild thickening. Yeah.
And it is dilated. And there is nodular thickening. Okay.
Okay.
With a little bit of calcification also because it is especially the left coronary cusp seems to be a little more thick, nodular, and probably calcified.
That's right.
Okay. Then on the other side, you can see the pulmonary arteries, the size of which is equal to the aorta. Okay, fine.
It's not grossly large. Yeah.
So you can say what is happening. By atrial dilatation, you have to say. The pulmonary veins are dilated. The mitral valve we have already discussed. But you look at the tricuspid valve. Because when there is a two-valve involvement, a rheumatic, look at the third valve also. You are less likely to miss. So look at the tricuspid valve also. Okay, this tricuspid valve seems to be normal.
It is well coapting.
It's well coapting and opening is normal.
Is there any that myocardium of the left ventricle in this view? Is it normal or does it have some pattern? That also you have to look into. It may not be there, but this doesn't look like a normal, absolutely normal myocardium, the left ventricle. But you have to. Pardon?
So septum.
You have to look into that. You have to look into that and tell the finding. Then you have to go further to clarify that. Next.
Yeah.
Yes. Okay. Then we will not ask question because you should know assessment of severity of AR. Okay. Severe AR. So we are interested in MR and AS and PA pressure. So MR is significant.
All right. Yeah.
That's what we said. No, so when S3 is there and the hypodermic apex is there, it must be severe MR.
Okay.
Yeah,
You can
that
say
is
that
moderate.
MR is significant and there is no MS, significant MS. So there was no inflow turbulence. Next one. The questions will be on the influence of one lesion on the other lesion. How will you modify that? Because we don't have time to discuss all those things. Okay, fine. Now we would like to know what is the PA pressure like.
Next.
Next.
Is there any TR?
No, just show us that is the IVC. It's
IVC.
quite
Collapse.
normal,
Small only.
not dilated,
And collapsing well.
collapsing well.
Sir,
Yeah.
he has
That's
probably
good.
received diuretic, sir.
Whatever it is, when the echo is done, patient is not in significant right heart failure.
Yes, certainly not much of right heart failure. Yeah, good.
Pick next one.
All
Okay,
diabetes.
fine measurements.
EF is
Okay, this is what
Yeah,
diastolic is
yeah, it's 75 and
Again,
50.
as
That's the,
absolutely put it as 7 and 5. And ejection fraction is 60. There is a complicated issue in presence of MR and AR. What is the timing of surgery? All those things. These things you should read. Next one. I'm interested only in the PA pressure in this case. Next. Okay.
we didn't get
These are favoring severe AR. Agreed.
next.
Next.
Yeah, what is this?
Yes.
AR.
This is
Yes.
aortic gradient. Do you think the patient has aortic stenosis? That's the next question.
That may flow related.
It could be flow related. Because looking at the AR, it is pressure after time, all those things, it is severe. And it may not be 35 because the person has put the marker beyond that spectrum. Okay. You have TR.
AML flutter can be noted in the others.
Yeah.
okay.
Because we have to finish it in time.
I
It's
think we
already.
stop here, sir. What do you say, sir?
Yeah.
We can go on and on.
Any idea about that TR?
not show
TR
anything.
is there. TR jet is there. Okay, fine.
ड्रॉप टी तो नहीं किया इसका
Just 3. So it may be just
ड्रॉप टी
mild pulmonary hypertension.
करवा दीजिए और ऑक्सीजन you should continue on oxygen for some more time.
Okay.
He should improve. He should improve, hopefully.
Next. Next, forward.
Possibly उसको क्या नाम है इसका इधर इन्फेक्शन और
Okay.
हाँ उसको था राइट साइडेड पे इसको राइट साइड साइनस है इसको कुछ करने के लिए बट चेस्ट एक्सरे में कुछ नहीं दिख रहा है इसको मेरे ख्याल में एंटीबायोटिक भी देना पड़ेगा सेफ्ट्राक्सोन का अगर दे देंगे इसको सेफ्ट्राक्सोन इसको 1 घंटे तक वेट करेंगे 9 बजे तक फिर देखेंगे क्या करना है
There's some background noise. There's some background noise from somebody.
But the thing is, here you should not put in mild aortic stenosis because you should have more data to diagnose aortic stenosis in presence of severe AR.
Yeah,
the simple one, which is very simple, is Doppler velocity index. That whenever there is a hyperdynamic flow, because if it is a high flow, low gradient.
Take the LV outflow. Yeah, you take LV outflow spectral envelope and the aortic envelope and see what is the ratio. Right? More than 4, obviously, severe aortic stenosis. Here it may be just 1 or 1.5. It's not AS. Okay. So we agree with most of this moderate LV dysfunction. I do not know because we have only LV ejection fraction, which is 60%.
60.
In setting of mitral regurgitation, 60% is the lower cutoff. In aortic regurgitation, 50 to 55 is lower cutoff. So here it's a mix. I would still think that LV is well preserved and maybe the right time to intervene because she has symptoms. Yeah.
RV dysfunction also you should be careful because you don't have enough data to say.
I was about to ask you that only whether TAPSI is at least the basic thing, TAPSI or fractional area change. 2 things.
And you will be asked about strain pattern nowadays. In echocardiogram, RV strain and all the other parameters of RV dysfunction, because we know that you may be familiar with LV dysfunction, but we will ask questions on RV dysfunction. What are the echocardiographic parameters to assess RV dysfunction other than TAPSI? TAPSI you are doing routinely. It's a very simple thing. So whether you have gone for RV, volume indices. Okay,
Volume indices.
whether you have gone for the strain imaging and the parameters of strain imaging. So that you should read and you should be prepared, because you have been presenting very well. You have done the good homework. You have answered majority of the questions very well. So we are very happy with that. But we will be in such situations, we will be asking about RV dysfunction and the timing of surgery, whether surgery is indicated or not. Definitely surgery is indicated. Now, risk stratification and Arun has appeared indicating that we have to stop.
Okay, just tell us what is the surgical approach to this patient. There is significant symptoms with two valve preatal lesions. What will be the approach in a 47-year-old female?
Double valve replacement. So we would go for double valve replacement.
Mechanical or bioprocesses?
So age is 46
Age
only,
is
so we have to go for
46
surgical
only,
replacement.
so surgical and not bioprosthetic. We would
We will
like
choose
metallic.
Bileaflet.
And
Unless
you
there
will
is
need a mechanical process for both.
Unless there is a contraindication
To
for VKS.
anticoagulation or this?
Which doesn't seem from the history. So we'll go for surgical aortic valve replacement as well as surgical mitral valve replacement, and place in a metallic processes in both.
Enough, Venu. I hope we have not overstepped too much.
No.
Yes. What is operative risk? That's my final question. What is operative risk for this patient?
Less than 3%.
The standard literature data, that's all, not your personal experience. Mitral valve replacement, aortic valve replacement, and double valve replacement with reasonable LV function. It's around 8 to 10%. Double valve replacement.
10%.
Okay.
Total
STI
valve replacement.
data. These are the questions that will be asked, because the other is easy. That is double valve replacement. And when it is double valve replacement in a young patient, it is better go for metallic processes, all those things. Dr. Arun, is it okay for today?
Yes.
Yeah, fair enough. Thank you. So
I think I think appreciate the students have done good homework.
yeah, they have done well.
That's the number one thing.
Fortunately, we
But
have
they
done
did a
most of
really
the
good-
talking, but it doesn't matter. Right?
They have answered very well. They were confident in answering the question. Venkatraj presented the case beautifully with a good history, a little elaborate, but excellent presentation of the case, excellent discussion. We are very happy. I am very happy.
Thank you, sir.
Yeah, over to Venu and Arun.
Yeah, I leave it to Arun to say the last few words. Arun?
Thank you, sir. I think both teams congratulate both the teams for having done very well, and you're getting accolades from the leading examiners in the country. So I think that should be Philip for you. You can stop sharing your slide. And good presentation by Dr. Venkat and Dr. Bharat and Dr. Subhash as well for helping him. And thank you, Dr. Harjit, Dr. Samir, who have come share the Kashmir as well. And excellent discussion led by our eminent experts, Taragan sir, Sudhirma sir, Hilal sir. He was silent most of the time, but he was, students more than made up for that. Wonderful discussion. And thank you, Srinivas sir, as well for leading the discussion. We were happy to have that excellent discussion by Dr. Kavita Sharma from HFSA, from John Hopkins, and it was a very good presentation on management of HFAI. I think the relevant things in the current scenario has been highlighted. I hope there will be a very good refresher for the exams, for the upcoming exams for all the final years, and for all those who attended as well. I think this was a very good discussion. Should also thank the entire team, Venu sir, for staying back. I think you should all be aware that there are multiple sessions that going on, and having teamed up with international partners, we are actually, this program is going all over the world, and there's a nursing program simultaneously being run with a huge attendance, and so is this this program. And due credit should go to Chopra sir, Abraham and sir, Harish sir, Venu sir, and Dr. Sarjan. And thank you, Sumita, the Sun Pharma, Hallmark team, everyone for having this thing going on. And for the students, well presented. And just one word from my side, when you get a double valve disease, you don't automatically tell double valve replacement. maybe there is a role in replacing one and trying to repair the other so that you can remove the morbidity and the long-term outcomes as well. That's what Taran sir and Sudhema sir were trying to help you out. So we'll come back next month for the December edition of Heart Failure Masterclass 2025. Till then, thank you all for joining. Good night and advance. Keep stay safe and good night.
Good night.
Good night.